So I always have trouble when I try to record directly in the PowerPoint. So we'll see if this actually works. Officially, we are on take one. So we'll see how many takes it takes me to actually get this to record. So in this lecture, we're going to talk about, I guess, renal and urinary systems. This is a pretty basic. I guess that's really just my opinion, but a pretty basic group of things that we're going to talk about with urinary function. It's very common. Lots of people experience urinary difficulty, especially in regards to what we're going to talk about here in this particular lecture. So we'll talk about urinary tract infections. We will talk about kidney stones. We'll talk about kidney infection. And then the last thing will be just a brief overview of polycystic kidney disease. So that's the renal part of this, I suppose. So urinary tract infections are really something in the healthcare world that we see a lot, not only in the inpatient setting, but also in the outpatient world. I myself have been to a doctor before because of symptoms associated with some type of urinary tract infection, whether that be a lower urinary tract infection such as cystitis or even an upper urinary tract infection like pyelonephritis. And both of those we will talk about. We see a lot of our inpatients have urinary tract infections. Older patients, oftentimes they're more at risk. And so this is definitely something that you're going to be encountering in your world of nursing as you become a nurse. So cystitis is the first thing we'll talk about, and this is what we're going to refer to when I'm talking about like a urinary tract infection. So cystitis actually is the medical term for inflammation of the bladder. Most of the time, that inflammation is caused by some type of bacterial infection, and that's what we typically refer to as a urinary tract infection. Now, urinary tract has both upper and lower parts to it. As you can see in this particular picture, with the lower part would be like the bladder and the urethra, and then the upper part would be the ureter and the kidneys. Now, any of that can become infected, but usually when we talk about UTIs, we're talking about a bladder infection, really, or like I said, cystitis. In addition to bacterial inflammation, cystitis can also occur because of a reaction to certain types of drugs, radiation therapy, other types of irritants like feminine hygiene sprays, spermicidal jellies, or even long-term use of a catheter. Cystitis can additionally occur as a complication of some other type of illness. So we'll talk about, as we move along, we'll talk about some of the signs and symptoms associated with urinary tract infections, but I'm guessing that there are some of you who are sitting here listening to this lecture who have maybe experienced a UTI, especially the ladies in the room, because it is, like I said, pretty common. So as we move through this particular lecture, think about the things that you experienced yourself, and how is that consistent with what we're talking about here? Kind of gives you something tangible to attach this particular problem to. So we have lots of reasons why a person might develop a urinary tract infection. So those are our risk factors. So when we're doing our assessment on our patient, we're looking at different types of risk factors. to help add to our assessment, but also to identify those people who maybe need education in terms of prevention. So we'll talk about a few of these. First one on the list is women ages 18 to 30. Women have a much shorter urethra than men do, and so they are just more likely to develop urinary tract infections. So what happens here is bacteria enter through the urinary meatus and kind of make their way up the urethra into the bladder, and so on, and so forth. And just the physical anatomy, in addition to the length of the urethra, just the anatomical location and how close it is to other orifices, such as like the vaginal opening, as well as the anus, really puts some additional factors into why women are at increased risk for your UTIs. Sexual activity increases your risk as well. Again, we have some close proximity to different tissues that may or may not be particularly clean. I don't mean to say that people are dirty, but there's bacteria there that are meant to be maybe in one place, but not in the urinary tract. The urinary tract is actually sterile. Unlike the GI tract, which is not. So when we have certain types of bacteria, especially E. coli, that's a normal flora in the gut, and that the GI system makes its exit very close to the urethra, we have a potential for transfer of that bacteria from one opening to another. There's actually a thing that is referred to as honeymoon cystitis for all of those individuals who are newlyweds and are really just genuinely enjoying time with their partner. We can see that time period as when someone starts to develop urinary tract infections. Diabetes, this is an endocrine problem that leads to inability to control blood glucose. In particular, blood glucose can become really high. Now, when blood glucose gets to a certain level, I think once it gets to about, I want to say 200, but don't quote me on that. But what I'm going with here is the fact that once the blood sugar level gets to a certain point, that extra glucose starts to spill over into the urine. And so when that happens, we have this food source for bacteria now to feast on. So that is why patients who are diabetic are at increased risk, especially if their blood sugars are out of control. Poor hygiene. We need to make sure that we are teaching proper hygiene techniques, not just to men, but also in particular to women. We want to make sure that they are cleansing away from the urethra and not towards the urethral opening, so that we're not inadvertently dragging pathogens into an environment that should be sterile. Another thing to consider with poor hygiene might be your patient who perhaps is incontinence, or who has incontinence. As people age, that can be a problem. Having children kind of it just messes everything up down there. That can lead to some incontinence, and you guys should have talked about incontinence in your fundamentals class, the different types of incontinence, so we don't really cover that here. But when you think about the person who suffers from incontinence, urinary incontinence, or even fecal incontinence, oftentimes you will find that they have adjusted to that thing in their life, that annoying problem, I guess you could say, in their life, by wearing incontinent briefs or incontinent pads. And so because of that, you have this opportunity for soiled material to be close up to the urinary meatus. Now, this is true for men as well as women in this case. So if patients are wearing incontinent briefs or incontinent pads, we need to make sure that they understand that those need to be changed routinely and frequently. If they are having just like you would a baby, you don't leave them in a soggy diaper all day long. When they're wet, you want to make sure that they are now clean and dry. And so we want to encourage that same type of behavior in our adult patients who have incontinence. So whatever factor might play into why a patient is having poor hygiene, that's definitely something that we can provide some education for. Estrogen deficiency oftentimes occurs, and this is referring to women, occurs as women get older. Not oftentimes, it just does. It happens. Bodies stop producing estrogen. Our postmenopausal women don't produce the estrogen like they did when they were younger, and that leads to drying out of mucosal tissue, which increases their risk for a UTI. Catheterization, I'll talk a little bit more about catheterization on the next slide, going to CAUTI. This is a huge deal, especially if you're going into acute care, but also if you're considering practicing in long-term care. CAUTIs are a really big deal, and catheterization, as you learned in skills lab, is a sterile procedure. As I mentioned, the urinary tract is sterile, and so when we catheterize that system, we maintain sterile technique during catheterization. And if we break sterility during the insertion of a catheter, then we can cause a UTI in our patients. Renal calculi, we talk about that here in a little bit. That's a kidney stone. This can lead to urinary tract infections simply because of obstruction of outflow of urine and damage to the interior mucosal linings of the urinary tract. So there's that. And then the last one on here is incomplete bladder emptying. Again, if you have urine that sits in the bladder when it's not supposed to. Now, we always have a small amount of residual urine that's left inside the bladder, but if it's excessive amount of urine that's left and we have a large residual, then it just becomes this medium for which bacteria can grow. One group of individuals who can have this happen are pregnant women, simply because the baby, as it grows, starts to push on the bladder. If you're a woman, you've been pregnant, you've probably felt them jumping up and down on your bladder from time to time, but it is something that can occur with pregnancy, that incomplete bladder emptying. So CAUTI. So what I want to talk about is, what is a CAUTI? Well, it stands for catheter-associated urinary tract infection. This is an example. CAUTI prevention is an example of evidence-based practice. So because of that, there are a variety of things that we do to help prevent urinary tract infections in our patients who have catheters. And first and foremost, as I mentioned, would be proper insertion technique. You guys learned how to insert a catheter using sterile technique. So that is the first step of CAUTI prevention. The next thing to consider is whether or not this patient actually needs to have a catheter. Now, there are a specific list of legitimate reasons why a person should have a urinary catheter. You can see this list here. Urinary retention is one that always kind of gets me. So with urinary retention, your patient is unable to void independently. Maybe we've done a bladder scan. We're like, oh my gosh, they have so much urine in their bladder for whatever reason, maybe they're post-op or something like that, and we put a catheter in, which is appropriate. It's an appropriate thing to do. But then the next question is, how long do we leave that catheter in before we take it out and determine there's no urinary retention? That honestly is a question I have never had fully answered, but the best answer that I have received is this. When we have a patient who has urinary retention and we put in a urinary catheter, we want to start the patient on some type of medication, perhaps, that is going to help with urinary retention, some type of Flomax or something like that that kind of dilates the ureters and whatnot. Once those medications have been started, then we can kind of wait 24 hours and then take the catheter out. And kind of see what happens. Sometimes that's sufficient and the patient starts voiding independently. Other times it isn't, and maybe we have to do in and out catheter a few times before we consider anchoring a Foley catheter again. So that's a little spiel about urinary retention. Just because someone has it doesn't mean that means they need a catheter indefinitely. We need to be doing something to try to treat the problem with the retention. It could just be a simple matter of, like our post-operative patients, how the bladder kind of falls asleep, becomes lazy because of the anesthetics and things like that. So maybe we need to, take it out after 24 hours. In fact, several times you'll notice when you're in the hospital, if you have a post-operative patient that comes back from surgery with a catheter in place, there will be an order to discontinue the catheter like post-op day 2. And it's for that reason that we've learned that sometimes it takes a little bit of time for the bladder to kind of wake up. When we talk about accurate intake and output on critically ill patients, this doesn't just mean someone who has strict INO necessarily. If a patient is able to get up and void, then that is really the best way to keep track of intake and output. But the key here is the critically ill patient. When you start working with patients who are very critically ill, one of the things that we monitor is their urinary output, because not only does it tell us about fluid balance, but it also tells us that the kidneys are being perfused and that they are working. And that can be really important when you're giving medications like vasopressive type medications to help maintain a perfusing blood pressure. So it kind of squeezes down the vessels so that blood pressure can be maintained. And what can happen is the blood vessels to the kidneys can get squeezed down so tight that the kidneys no longer are getting perfused. So that's what we're talking about when we talk about accurate intake and output of critically ill patients. And kind of a subcategory of this, if you will, would be the patient who's on high dose diuretics. And that is the person who is probably getting some kind of diuretic drip like bumetanide or furosemide. They're getting a continuous infusion of that diuretic, and so we want to again take accurate intake and output of those patients. Certain perioperative situations, if you have someone who's had a bladder surgery, if you've had someone who's had a big belly surgery, sometimes we will keep a catheter in for those instances. If we have someone who has a wound of some sort where their incontinence is going to impede the healing of the wound, that might be an appropriate case. Now, incontinence in and of itself is not a reason to have a catheter placed, because the risk outweighs the benefit in that case. But if someone is incontinent and they have a big, stage 3 wound, or they have horrible incontinence associated dermatitis, we may have to put a catheter in for a time until that skin heals. So with our incontinent patients, really the best thing to do is good moisture control with things like moisture barriers and frequent linen changes and things like that, as opposed to a catheter. But if they have a big wound and the incontinence is impeding that, then yeah, we can definitely make that happen. With immobilization, this often occurs with someone who has like a spinal fracture of some sort that's unstable, hip fractures that are unstable. I know when I work on the ortho unit, here in the hospital, when you have someone who comes in with a hip fracture, one of the first things that we do is we put in a urinary catheter. And that's because we don't want them moving around, because that fracture is unstable, could cause more damage. Now, after they come back from surgery and they've had that hip stabilized, whether replacement or otherwise, then they don't really need a catheter anymore, because they are no longer need to be immobilized. And then lastly, end of life care. And this just makes sense. Now, as a patient nears the end of life, and different organ systems start to shut down, there may not really be a need for a catheter, but in that particular instance where someone is actively dying, it is completely appropriate to have a catheter. So on the right side of this slide, you see some of the things that we do as nurses to help prevent clotting. So remember, the first thing was insertion technique, and then, WTF, why the Foley, is it legit? But then also these other things are what we can do as nurses to prevent UTI. Now, a couple of the things that I see happen most commonly that nurses will miss is that they don't allow for free-flowing tubing. Now, it can be very challenging. You want your tubing to be free of loops, dependent loops, so that urine doesn't have to travel uphill, because it's gravity. It can't really go uphill, so you don't want that urine sitting in the tubing and potentially backflowing. We want to make sure we keep the catheter bag below the level of the bladder, again, so that it doesn't backflow that urine back up into the bladder. When we're emptying a catheter, and you guys have had the opportunity to look at this, we don't want the spout touching anything. We want to take care that we're not allowing that to happen. The system should stay closed. Now, for most of what you know, that just makes sense. It all comes together in one piece. But there are instances where, like for example, sometimes patients may have a bladder irrigation system going, and perhaps they've gotten a clot, and so it won't flow. The urine and the irrigation won't flow, and so we have to kind of open up the system and irrigate it. And of course, that should be done in a sterile fashion, but we want to keep from connecting and disconnecting the tubing in the bag from the actual catheter. Of course, empty it regularly. Make sure you put a securement device in place. There's a chart in your book that you can see that I've referenced here that has this stuff on there. Proper cleaning and maintenance. When our patients have urinary catheters, we really want to be making sure that they are getting a CHG bath, head to toe. That should just be a CHG bath, but also that we're cleaning the urinary catheter away from the body with the chlorhexidine gluconate, so that it decreases the potential for bacteria to make its way back up the urethra. So this, I kind of have already mentioned what's on this slide. This is basically what happens, how a person gets urinary tract infection. Bacteria enters the sterile bladder. It causes inflammation. It can either be lower urinary tract or upper urinary tract. So what does your patient feel like who has a urinary tract infection? They can have several symptoms. Dysuria is pain with urination. That's pretty common. They can also experience burning, urinary frequency, hematuria, which would be blood in the urine. We could see them, or we could have them report suprapubic pain, or pain kind of in that very lower abdomen. Excuse me. And then there can also be some systemic signs of infection like fever and that kind of thing. Not always, but there definitely could be. Urinating in very small amounts very frequently, just because you feel like you have to pee all of the time. There are a couple of things that are unique to our elderly patients, and that is number one, falling. All of a sudden, you have somebody who normally is up and steady on their feet. They've experienced a fall and confusion. Either an new onset of confusion, or someone who maybe is confused at baseline has gotten worse. With our older patients, those are oftentimes the only sign that they have that tells us that they have a urinary tract infection. So to diagnose a urinary tract infection, we're going to get a urine sample, and we talked in Skills Lab how to collect a clean catch midstream urine sample, which is probably the best way to do that. We also can go in and get a sterile sample by doing an in and out catheter on a patient. And then we need to get a culture. Now, we won't necessarily wait for a culture to come back before we actually give them antibiotics, simply because we know that for the most part, a majority of urinary tract infections are caused by E. coli. And so the provider will go ahead and order that. But the culture will be done, and if there's something that's not E. coli, then they can always change the antibiotic if they need to. Sometimes analgesics are needed. Urinary analgesics are probably the one that I see given the most, and that's a medication called pyridium. I can't remember the generic name of that medication. You can actually get like a lower dose strength over the counter. It's called Azo, but providers will oftentimes prescribe this medication. It really just anesthetizes, makes it numb, is what I'm trying to say, the tissue there, so that when you urinate, you don't feel that pain and that burning. It does cause your urine to turn like an orangish color, so you should probably let your patient know about that. It can stain the clothes when it's orange. It's also been known to, in some people, cause tears to turn orange, or even sweat to turn orange. And I've taken Pyridium. I've never had that happen to me before, but just something to kind of consider. When we look at an actual urinalysis, though, there are a couple of things that we're probably going to see if a patient actually has a urinary tract infection. First of all, we're probably going to see that the UA is positive for leukocyte esterase and nitrates. Both of those, the presence of both of those is going to be a good indicator that the patient has a urinary tract infection. So nitrites or nitrates, they actually indicate the presence of a bacteria, and leukocyte esterase is that's just an enzyme that's produced by leukocytes. So the white blood cells are in the urine doing some type of thing. We don't always see on a urinary or urinalysis the presence of bacteria, which is interesting. So you could see it either positive or negative for bacteria, but urinalysis will also tell you what color it is, the turbidity, kind of like how murky, I guess it is. And then odor can be something. Now, UA won't tell you odor, but maybe it will tell you if there's an odor, but as a nurse, you can assess the odor of the urine, and someone with a UTI typically has a pretty foul-smelling urine. If we let a urinary tract infection go, it could lead to pyelonephritis. In other words, the infection could get a little bit higher up in the urinary tract system. So that's one complication. Or if, just like any bacterial infection, if we don't complete the antibiotic course, we could always end up with resistance. one of the bacterial resistant infections we talked about way back when was VRE, and that's a common resistant one that we see in urine. So prevention education is really a good thing for nursing to do, either before or after. I mean, if someone does develop a urinary tract infection, we can still educate them about things that they need to be careful of. That might include things like voiding after sexual intercourse, avoiding chemical irritants, especially things like spermicidal jelly. Douching sometimes can be an irritant. Bubble baths, that soap can sit in it, can be an irritant. If a patient is estrogen deficient, we can always replace the estrogen for them. Sometimes it doesn't even have to be a systemic estrogen. It can be like an estrogen jelly. That's more of a topical preparation. We want to teach them to clean appropriately. For women, that is from front to back or away from the urinary meatus, not towards it. Cotton underpants, that is going to allow for good airflow so that we don't get bacteria kind of hanging out in a warm, moist place. They don't get trapped in there. So that's some good education. If a patient has a UTI, we're going to encourage increased fluid intake, up to 2 to 3 liters of fluid. The goal here is to have kind of a pale yellow urine. Now, if someone is on antibiotics, or nephrotoxic type antibiotics, really heavy duty ones, we may want them to increase their fluid intake. But the best way to tell if someone's getting enough fluid intake for this problem is that the color of their urine is pale yellow. Not clear, not no color, not absence of color, but a very pale yellow color. We talked about how with bacteria we have to have an antibiotic. So whatever infection is there, we want to give medications for. Oftentimes our patients might take something like Bactrim or Cipro. Those are a couple of pretty common type medications. And then for discomfort, I mean, we can use heating pads. We don't always have to use medications. Analgesics like Tylenol can be helpful. And then again, I mentioned that pyridium is something that we can see prescribed. So we'll kind of move up the chain of the urinary tract and talk a little bit about pyelonephritis. So pyelonephritis is actually the most common of the renal diseases. Young women are most affected, as well as elderly are at increased risk, and we kind of talked about some of the reasons why those populations are at increased risk for UTIs, and the same kind of other risk factors. Well, the greatest risk factor for pyelonephritis is a history of multiple or frequent urinary tract infections. We can also see something called vesicoureteral reflux. In other words, urine is kind of refluxing back up into the kidneys, causing irritation, inflammation, infection. An indwelling urinary catheter. Another reason why we don't want to have a catheter, we could cause kidney infections. Pregnancy is a risk factor for pyelo. Kidney stones is a risk factor for pyelo, especially if it obstructs the ureter as it goes down into the bladder. All of that can kind of back up. So our risk factors are pretty similar to what we saw with urinary tract infections, lower urinary tract infections or cystitis. So basic pathophysiology, the bacteria enters through the urinary meatus, travels up through the bladder, up through the ureters, and then it starts to cause problems with the kidneys. Again, the most common offending bacteria is E. coli, and we discussed why that is the case when we talked about the cystitis. Clinical manifestations are pretty similar to UTI. A patient may or may not have those things like dysuria and burning and stuff like that when they urinate. You have to remember that this is a major organ that is infected. And so symptoms might be a little bit more severe and systemic. So those malaise, fever, chills, those things can happen more likely with a pyelo than with just a simple cystitis. Something that we see quite a bit is nausea and vomiting. That can be pretty severe. Also back or flank pain. Now your flank is in that kind of costovertebral angle, just kind of that, I don't know, like if you reach your hands around your side and put them right there where your kidneys are, that's your flank, and where you would palpate for costovertebral angle tenderness. But essentially, you're going to see more of a systemic sign of infection in that nausea and vomiting. If we look at labs, not only would we get a urinalysis with a culture, but we may at this point get a CBC. The diagnosis, when the providers diagnose pyelonephritis, it's made based on clinical symptoms combined with that urinalysis, where we see pyuria, which is pus in the urine, bacteria in the urine, blood in the urine. And if we draw a CBC, it might show an elevated white blood count with a left shift. And if you recall, left shift is when we have an increase in immature neutrophils. We don't typically do CAT scan like imaging when someone has pyelonephritis. But if we're not really certain if that's what it definitely is something that a provider may order. If this CAT scan is ordered, it might show some kind of hydronephrosis, in other words, fluid kind of built up around and retained within the kidney. We're still going to give antibiotics to these patients, just like we did with a urinary tract infection. Same kind of thing. Usually Bactrim is typically effective and cheap. Cipro is also commonly encouraged. We're going to encourage the patient to drink plenty of fluids. And sometimes we hear some things about cranberry juice. Now, I've read studies that are for cranberry juice. I've read studies that are against cranberry juice. I don't know. I guess there's two sides to everything. It alters the pH of the urine. It can prevent bacteria from sticking to the bladder wall. So there are some things that I've read that cranberry juice can do. And it's not like cran grape juice that we're talking about here. We're talking about straight up, just cranberry juice, not cranberry juice cocktail, but cranberry juice. So it can be bitter and unpleasant. Some people don't like it. But it is something that I think your book talks about, and that you may hear other people talk about or ask about. It's not going to hurt anybody to drink cranberry juice when they have a UTI. In fact, I do it more than anything. For me personally, I think it just encourages me to drink more fluid, makes me more cognizant of the fact I've got this infection and I want it to go away, and so I'm going to start drinking much more fluid. Now, I do know some urologists that I have worked with who have actually recommended cranberry pills to their patients who have recurrent and frequent urinary tract infections, and whether that's lower or upper urinary tract infections. So there must be some sort of merit associated with it. I just don't know what all of the research actually indicates there. If a patient, complications, I guess, of pyelonephritis could not only be recurrent infection, but also sepsis. So we talked a little bit about sepsis back when we discussed infection. we would call this urosepsis because it started as a urinary tract infection. So if we remember way back when that spectrum of sepsis, we could see more pronounced signs of infection and systemic signs of multiple system involvement, whether that be changes in blood pressure or heart rate, cognition, a variety of different things like that. So normally when I have you all face to face in a class, I have you watch this video that it's a Seinfeld clip where it shows Kramer when he has a kidney stone. And in this virtual environment, this is actually something that you do as an independent. I think it's a discussion board or something like that. So when you go through that video and you look at that, you'll be asked, what kinds of signs and symptoms did you see, and how is that consistent with what you learned about kidney stones? So basically what happens with a kidney stone is, for some reason or another, sometimes it can be dehydration, can be genetic reasons, an excessive amount of calcium, different reasons why patients can develop kidney stones. But you have a stone that's in the kidney, and a lot of times, not always, but a lot of times when the stone is actually in the kidney, it doesn't really cause a lot of pain. As that stone starts to move out of the kidney and make its way down the ureters, it is very, very painful. Patients will experience intense pain, sometimes accompanied by nausea and vomiting. You can almost track the location of the kidney stone as it moves from the kidney down towards the bladder. It'll kind of wrap around from the flank down into the sides. Men can experience referred pain into the scrotum. Women also can experience referred pain into like the vulva region. It's very, very painful. If anybody has ever had a kidney stone, they can attest to how painful a kidney stone actually is. Now, as that stone makes its way down the ureter, where it's kind of like this jagged shard of stone scratching its way down the ureter, causing, ripping tissue out, and just imagine, once it gets into the bladder, the pain stops, because now we have this reservoir in which the stone can sit and have room to kind of hang out. The pain will then pick back up again when it starts to leave the body, starts to leave the bladder through the urethra. So you have a couple of different times when this patient's going to have pains. Most of the time, a stone will pass on its own, which is fine. It's uncomfortable, to say the least. It causes, it can lead to infection. It can cause some hematuria. But for the most part, most of the time, stones can and will pass on their own. The best thing to do is to encourage patients to drink lots and lots of fluid to really flush it out. We may also instruct a patient to strain their urine if they happen to collect a stone that they've passed independently. They may be instructed to bring that in for analysis. Sometimes there are dietary things for some people that they can do to help prevent stone formation in the future. So what becomes problematic is if the stone is obstructing. So whether the stone is obstructing somewhere in the ureter, or if it's a bladder outlet obstruction where urine filtrate is not allowed to leave the system, then it can become really problematic for your patient. And that's typically when your patient is going to require some kind of surgical intervention. Let me tell you a couple of different terms. Urolithiasis is one term that we used for stones within the urinary system. And that term might vary depending on the actual location of the stone. For example, nephrolithiasis is a stone that's in the kidney. Ureterolithiasis is a stone that's in the ureter. So it really just depends on the actual location of the stone on what you might see a provider refer to it as. Other risk factors: dehydration is a key determinant in the development of stones. Caucasian males are more likely to develop stones, especially those who live in the southeastern United States. I don't know why that is. Maybe increased heat and sweating or something. So if a patient is suspected to have a kidney stone, we are going to get a CAT scan. Most likely, imaging is going to be done. It could be a simple x-ray, but more likely it's going to be a CAT scan. And like I said, if the stone isn't obstructing, then they're going to get pain control. Especially immediately, we'll likely give some type of IV pain medication, such as some opioid medicine like Dilaudid or morphine. A really good IV pain medicine to give patients with kidney stones is Toradol. It's also known as ketorolac. It's actually an NSAID. It's really nice because it doesn't cause the same types of negative type side effects that opioids do, like the drowsiness and respiratory depression and nausea and stuff like that. And it tends to work really, really well for patients with kidney stones. However, it is dose limiting. We can only give it so many times because it's actually hard on the kidneys. It's an NSAID, so we can't just give it indefinitely to our patients. We may give medication as like Flomax that can be used to relax the musculature to aid in the stone passage. If a patient's experiencing vomiting, we could give an antiemetic. Obstructing stone, I think I've talked about all of that. Surgical intervention. So that's required when the stone either doesn't pass after a period of about 4 to 6 weeks, or if it's obstructing. Typically, if it's greater than 10 millimeters, it's causing obstruction. The pain is really uncontrolled, or if there's sign of infection, they may go in and do some type of surgery. A ureteroscopy is one type of surgery that could be done. This is where a scope is inserted through the urethra and then the bladder and into the ureter. There may be an external incision on the back, so just FYI, if a patient wakes up with a bruise on their back, that's just, oh no, that's not a ureteroscopy, that's the next one. Ureteroscopy is just a scope that's inserted through the urethra, sorry about that. And they go in, they crush the stone, they flush it out. Sometimes they'll place a stent actually, and a stent is just like a scaffolding type device that holds open the ureter so that the urine can then flow out of the kidneys. A percutaneous nephrolithotomy, that's the one that I was saying they'll make an incision on the back. That's used for stones that are bigger. They may also be used for a type of stone called a staghorn calculi, and those calculi, they're in the kidney, and they kind of have dug their little tendrils into like the little nooks and crannies inside of the kidney. So this one, they are going to make that external incision in the back. It's not big, it's very, very small, and they kind of go in that way. They may do that in conjunction with a ureteroscopy, or they may not, but you can see this picture on the right is a nephrolithotomy. They go in and they take that out. Let's see, another one they might do is something called an extracorporeal shockwave lithotripsy. This can be used for both renal or ureteral stones, typically smaller in size. It's non-invasive, and it uses shock waves to break up the stone so the patient can have it. So the patient is submerged in water, and then they use these shock waves, and it pulverizes the stone. essentially the stones break up into sand. So regardless of which one of these procedures a patient has, because we've broken up a stone or whatever, we need them to be able to pass those stone fragments out. So lots of water that we're encouraging the patient to drink to kind of help flush that out. If they experience bleeding or bruising, such as with that nephrolithotomy, we can use ice kind of on that area. We just want to watch to make sure that it's not developing some type of blood collection like a hematoma. Infection could be something that we're worried about after the procedure, so we want to monitor them for signs of infection. It's likely that they're going to have some hematuria, so we want to make sure that they know that. And then again, we're probably going to be straining their urine. Pause here for a second and just go back to that whole stent thing. I just remembered. So I was mentioning that a stent is like this scaffolding type material that kind of pops open or holds open the ureter, so that the filtrate or urine can make its way from the kidney down into the bladder to exit. I've seen stents a couple of different ways. They can be completely internal, and if that is the case, once it's time for them to come out, the patient will follow up in the outpatient office typically, and they will use a ureteroscope like what you see on the left of this slide. They'll go in after and they'll pull it out. There's no sedation or anything like that. There's local anesthetic at the urinary meatus, where they just go in and they take this stent out. Another type of stent I've seen is where there's actually a string that is external that you can see. And when these patients come back that have a stent like that, they'll have that string kind of taped to their leg. We don't want to mess with that necessarily. We want to leave it taped to the leg. And when they go home, they are usually instructed on how to remove that themselves. And it's not difficult. I can imagine it might be very intimidating for a patient. But typically the best way to instruct them to remove that is to be in the shower, grab hold of that string, take a nice deep breath, count to 3 and pull it out. Of course, they don't want to keep pulling if they meet resistance or anything like that, but sounds a little barbaric to me, but it can be done. If a patient just can't do that, it's also something that can be done in the office. Someone can do that for them if they are unable to. All right, we're almost finished. We have just 3 more slides to go, and I'm going to just briefly talk about polycystic kidney disease. This is a genetic disorder. It leads to fluid-filled cysts. They're large. It's disturbing looking at these kidneys. These are actual kidneys that have polycystic kidney disease, but these cysts kind of build up along the kidney. And what happens is because of all of these cysts, because of the size of the cysts that's going on here, we start to have compression of surrounding structures, causing damage and ultimately reduced kidney function. There's a couple of different types. There is a childhood type, and I don't teach pediatric nursing, so I'll just leave it at that. And then there is another type. It's an autosomal dominant type. It happens in adults. Is actually fairly common. I don't know how common, but fairly common. And it can appear not only in the kidneys, but also in the liver, the spleen, and the pancreas. It typically appears between the ages of 30 and 40, and it will involve both of the kidneys. To me, this is very disturbing to think about, to look at. I read somewhere that each one of the kidneys can be up to 30 pounds. It's insane to me. They look to be about the size of a football, each one. I could not imagine having that inside of my abdominal cavity, but there we have it. Once it appears, it's pretty rapid in its onset, and there's no reversal of it. The only treatment for it, besides symptomatic treatment, is a kidney transplant, because the kidneys will end up failing. I did learn that if they do a kidney transplant, they often leave the old kidneys in place, and then they kind of start to atrophy over time, and then they'll just kind of stick the new kidney right in there. However, as I mentioned, because polycystic kidney disease can affect the liver, the spleen, the pancreas, if that is the case, while a kidney transplant will fix the kidney problem, it is not going to affect the liver and the spleen and the pancreas problems. So early on, the patient's not going to have any type of symptoms whatsoever. Oftentimes, hypertension is the first symptom that the patient will experience. They may complain of a headache that just won't go away. Then they may begin to experience signs that look like kidney stones or pyelonephritis, right? Hematuria, flank pain, renal calculi, costovertebral angle tenderness. You can imagine perhaps palpable kidneys as big as those bad boys would be. Maybe their abdomen looks larger in size. So we can treat the hypertension and the pain and UTIs and stuff like that. But like I said, there's no cure. At least half will develop renal failure and are going to need either dialysis or they're going to need kidney transplant. Definitive diagnosis is done through ultrasound. They also look and see what the blood vessels, I guess, to the kidney are doing. They may do a CAT scan or an MRI or something like that. If a patient does end up in end-stage renal disease, of course, HD is hemodialysis. PD is peritoneal dialysis. It's just a different type of dialysis. Now, I'm not going to go through renal dialysis. That's something that you'll learn in complex med surg. It's more of a complex medical problem, but that is something that these patients will experience eventually. So we can treat the hypertension, we can treat the infection and the pain. Smoking cessation is encouraged to help prevent complications. Other nursing interventions that we can do, fluid balance, we have to be careful with that. Patient could have not enough or too much fluid. Sometimes they're on restriction simply because the kidneys aren't able to filter all the fluid. So we want to make sure we're monitoring our fluid balance on our patient. That's old news. We know how to monitor fluid balance on a patient. Things like intake and output, daily weight, yada, 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 that kind of thing. We want to monitor for infections since they could have frequent urinary tract infections. Patient may be placed on a renal diet because their kidneys are not going to be able to excrete wastes. A renal diet includes low potassium and phosphorus. Protein recommendations, sodium restrictions, things like that. Commonly can have electrolyte imbalances. That's a big deal with renal failure. Electrolyte imbalances are, especially potassium, phosphorus, calcium. As far as salt, that's dependent on if they're wasting salt or retaining salt. So that's going to be unique to the patient on whatever it is that they're dealing with in terms of sodium intake. Okay, so that is all for urinary function. Please, as always, let me know if you have questions. I think the big thing to take away from urinary function is remember the kidneys have a lot to do with fluid balance. So we need to monitor that. They also have a lot to do with electrolytes, so we need to monitor that. And we've got an old concept of infection. So remember how we treat infection here in this setting. We just have some new ways in which the infection might manifest because we have a system-specific symptoms that we are dealing with. And then for our things like Pyelo and stones and UTIs, we want to really encourage a lot of fluid. Additionally, CODIs are a big deal, so make sure you understand prevention and the evidence-based practice around how to prevent CODIs. And I think those are the big things. So let me know if you have questions.